Hello and welcome. Today, my presentation is going to be on Crohn's disease. A quick description of the disease is that it is an inflammatory bowel disease that can affect anywhere from the esophagus all the way to the anus. But it is more prevalent in the terminal ileum in the small intestine and around the start of the colon, usually the S ending of colon. This is a condition where in certain spots of your gastrointestinal tract, you have inflammation in the intestinal wall and all four layers of them: the mucosa, submucosa, muscularis externa, and the serosa. Going a little bit more deeper into it, we have our microvilli and our villi that are also being damaged to it, which causes further things to it, but we'll get into those in a further time as well. This is also an autoimmune condition where your body's white blood cells are targeting its own healthy cells and killing them, causing inflammation among the intestinal wall. This does an autoimmune condition, as well as you might have just seen from the slide, is when your body is targeting its own tissues, and it is basically producing a lot of things that are basically going to be damaging that lining and whatnot as well. Here on the left side, we can see a normal intestinal surface where we see a normal intestinal wall and nothing's really wrong with it, and it's a very healthy intestine. Whereas on the right side, we see what happens in Crohn's disease, where we have also like intestinal surface, the fat wrapping around the outside of the intestinal wall, and the thickened wall, which causes the fissure, or it causes the stricture, and it causes the intestinal gap to get like thinner, so it's hard for food to pass through. Especially in Crohn's disease, what causes the pain specifically in a patient is where you have the normal intestine, which is on the left side. You go from that normal intestine into a smaller stricture, which is on the right side, and then back to a regular piece of intestine. So this is why there's so much pain in these patients, is because they're trying to force a piece of food through such a wide space, and then even just through a smaller space and then a wide space again. That little small space is just causing this much pain to those patients. And a way that I like to describe it to some people that want like a conception of it is like if you were to have a funnel, like two funnels facing each other, and have the thin part at the middle, that's exactly how it's going to be for a person with Crohn's disease. So it goes from a very wide piece of intestine to a small piece and then to a wide piece again. Here is a piece of inflamed intestine that I was able to retrieve from images, and you could see kind of like how beat up it is. It's really got a lot of inflammation going on the outsides of it. Some signs and symptoms of Crohn's disease. In Crohn's disease specifically, it's very hard to name a specific sign, like a telltale sign, like, and in Lyme's disease, where you have the bullseye sign that really indicates that this is Lyme's disease and nothing else. In Crohn's disease, it's a very hard thing to like get right and like to say, yeah, this is definitely Crohn's disease, because the symptoms and the signs just vary from patient to patient. Some of the more prevalent signs that we have seen from case to case and that we've noticed a trend along is specifically blood in the stool, extreme loss of weight, loss in appetite, loss in mood, poor mood, low energy, abdominal pain, nausea, and inflammation in the abdominal area. You would have blood in the stool because of the intestinal lining breaking down and then having an exposed site where you would have blood, and that blood would make its way throughout the intestinal tract and then obviously into your poop where you would see it. You would have an extreme loss in weight, you would have a loss in appetite, poor mood, and low energy, all contributing to these factors, which is the microvilli and the villi. These two things aren't absorbing the way they're supposed to because of the damaged intestinal wall. Then the microvilli and the villi are responsible for absorbing nutrients from your food and from your intestinal tract. And when you have these pieces of strictured intestines, they're not absorbing the nutrients the way they're supposed to, or they don't absorb them at all, which causes this extreme loss in weight, the loss of appetite because you don't feel like eating anything. You have a poor mood and a low energy because you're not getting the vitamins you need from your food, or the macromolecules. Not getting your proteins, your lipids, your fats, your nucleic acids. You're not getting any of that because of this damage to your intestinal wall, which is not allowing that nutrient absorption to take place. The causes of this disease and the triggers of it. Now, for Crohn's disease specifically, there is no cause, or there has not find a cause for it yet. Many say that it's genetic, and we can see that if we look at the history of it, and if we just look at the epidemiology of it, which we'll get into later as well. We'll see that there's been a common thing where people in the family pass it down through the genetics and whatnot. But actually, another thing that they have found out is through stress-related symptoms, and people that often go through stress-related instances at a younger age often develop Crohn's disease later on in their life. Some triggers of Crohn's disease can range from stress situations like taking an exam in school or making a stressful decision like a college, like applying for college or see if you got accepted. During those small little stressful periods are what lead to triggers and lead to a lot of abdominal pain for people like that. And even in work-related situations, if you're going off under a lot of stress at work, you could trigger Crohn's disease and basically go into a flare-up. Another trigger can be certain spicy foods like highly processed foods or foods that with a very high Scoville unit. Anything like that is going to be causing a lot of irritation to your gut. It's going to make your gut sensitive and it's going to not know what to do with it. And you could potentially throw up or have a lot of diarrhea or basically any other GI issues that we mentioned previously in the signs and the symptoms. Some more disease symptoms are the last five types, like we mentioned, blood in the stool, fatigue. Fever really isn't like a telltale sign or like a sign that we've seen in everything, or a sign we've seen specifically in Crohn's. It's kind of like what we see in everything. Mouth sores are actually going to be kind of more related to celiac than they are to Crohn's disease. I just thought that I included just because it was one of the signs one of the symptoms that we have seen before in previous cases. Um, the stomach aches, the cramps, the weight loss, the diarrhea. The diarrhea is actually going to come from when you pass the food through the intestines and it goes to that small piece and it goes to the big piece again. Now that it's made through that smaller piece, it's kind of be a lot smaller and it's going to be basically a lot more ran through. So that's the reason for the diarrhea as well. And it's been basically broken down a lot more than it needs to be because of those strictures in the intestines. The pathology and the origin of Crohn's disease. There is no origin from Crohn's disease specifically, rather than we have a few narratives that we can explore through previous research that we have found online. Genetics susceptibility genes like the NOD2 and the ATG16L1 one and the IRGM are commonly mutated. These genes specifically are a part of the immune response, so when they get affected, the immune system gets weaker, which makes this more prevalent for Crohn's disease to thrive in. Essentially, what happens is during a younger age when you're like going through puberty or whatnot, and I believe later on we mentioned that it's usually from people that are 15 to 35. Usually in that beginning time frame, from like 15 to 16, when people usually go through puberty, that is usually when these genes get affected, and that's when they start to show their like true colors and really get expressed throughout the system. That's when we really see people start to have signs and symptoms of it. As far as our immune function, we have an increase in pro-inflammatory cytokines. Examples can be TNF alpha, IL-12, IL-23, and then IFN-Y. Due to our susceptibility genes being mutated, which in turn promotes these cytokines for more inflammation. Diagnosis in order to have diagnosis, you would have to first get an endoscopy or a colonoscopy to get a biopsy sample through this. The diagnosis of Crohn's disease can be quite difficult to get to because of the very vague signs and the very vague things that we have seen before. It's such a hard thing to diagnose because people don't have the telltale sign of it, and it's kind of beating around the bush when you're trying to look for it specifically. But once you are able to get endoscopy or colonoscopy ordered, and people think that there's going to be something more intestinal or more something wrong with you than just a stomach ache, which a lot of people pass it off as, or some people usually just pass it off as, oh, it was a stomach bug. But once these symptoms start happening like frequently, like monthly, time after time, week after week, that's when we start to get a little bit more investigation, and then we had a colonoscopy, endoscopy, and that's when we'll see what we see right here. A cobblestone-like appearance appearing on the intestinal wall, and we can see that the inflammation has really took an effect here. And we see that cobblestone-like appearance where we have our strictures kind of like narrowing, and like the intestine itself has got to like very like more narrow essentially. Another way you could actually look for Crohn's disease is through a calprotectin test of the stool to see how much inflammation there is in the stool itself. At the moment, there are no cures for Crohn's disease, but we do have a couple methods of treatment right now. One of them is methotrexate. another one is Stelara, and another one is Remicade, which we'll get into further right now. Methotrexate is one of the ways we can treat Crohn's disease, and it's a medication that is a simple pill that you take in the morning or at the afternoon, depending on your case. This is used for a lot of cases where you have caught it in families, and basically you know that you have it in your genetics, and you're basically making sure that you could catch it out early for your offspring. Most of the cases, it is in mild cases of Crohn's disease, but if it gets to like a worser stage in later on in your life, that's when you want to look at other options because you don't want to just stay on medication that's not going to make you feel good. You want to increase the doses, and you only want to increase um, the medication when you have to, because if not, you're going to build a tolerance to it. If methotrexate doesn't work, our next option is going to be Remicade. Remicade is a continuous infusion that goes on for 2 hours, and depending on how critical the patient is and how much inflammation they have, it could lead to every 4 weeks or every 8 weeks of getting this intravenous infusion. Remicade is given through an intravenous access or an IV, which is more popularly known as, and it is diluted with saline in order to help get the medication throughout the patient as thoroughly as possible. Usually with Remicade, people often have a lot of allergic reactions to it, or people just don't feel good with it, so they are often given with Tylenol and Benadryl in order to combat these side effects. Stelara, this is more of a serious medication from Remicade and is basically more of a step up. So if you think about it, it's like a ladder. So you go methotrexate, you have Remicade, and then you have Stelara. Stelara is a more serious medication, and it is the last treatment before we consider other options like surgery. Again, just like Remicade, this is every 4 to 8 weeks, or it could be anywhere from 4 to 8 weeks, depending on the severity of the patient. And the way this is given is actually a subcutaneous injection. So this is where it differs from Remicade, and it is subcutaneous injection that is either administered from the patient or from a family member, depending on the patient's status. So as you can see on the picture I provided on the lower right-hand side, you can see that you can give it to anywhere of the fatty tissues of the body. So if you have a little bit of fat on your thighs, anywhere on your abdomen, your triceps, or kind of like on the lower extremities of your body, you could basically give it out to there. Surgery. Once all other methods of medication have been proved to not be effective towards battling the inflammation of the disease, we look at possible surgery routes. Bowel resection, anastomosis. This is one of the most common surgeries that we see where we remove the piece of inflamed intestine. So if you have a piece of intestine that is inflamed from here to here, what the surgeons would do is that they take this part out and they reconnect these two and then bring them closer together. That varies from patient to patient. So in the case that this piece of stricturing intestine is too long, where they can't reconnect two healthy ends back together, that would lead us to have a coleostomy or an ileostomy in place. And a coleostomy, what happens is it's kind of in the name where you want to let the rest of your colon heal. So basically, you take out one part of the healthy intestine. So if this is your colon, it's running transversely like this. You would take this part out and then face it outwards out of your abdomen. So you'd have a piece of intestine coming out of your abdomen and into an ostomy bag, which gets the rest of your name, the ostomy. So colostomy. And then again, the same thing is for the ileostomy. They would take a piece of your ileum, so they would take it running transversely, and they take it and it's pointing out, and now that is coming into an ostomy bag, which is basically a poop bag. Now, the reason they do this is in order to ensure the rest of the bowel heals and is able to recover. So maybe later down the road, they're able to take the ileostomy out or the coleostomy out and reconnect it to the rest of the intestine. So hopefully you can function regularly again. Not that you can't function regularly with a coleostomy or ileostomy, but you can start going to the bathroom regularly and actually using your anus to be able to go poop. Yeah, and it varies from patient to patient. This may be temporary, this may be permanent. It really does depend on how your body reacts and how they are able to go from this. But yeah, it really does depend. Another thing that I would like to mention is that just because you are getting this surgery does not mean you're getting rid of this disease. That's another thing that people really don't understand is that just because you get all of your inflamed piece of intestines out doesn't mean that Crohn's disease is gone forever. It's still a part of you and it's still in your genes. So because of that genetic mutation, like we mentioned earlier, that's still going to be there and it's going to affect other parts of your gastrointestinal tract. The prognosis of Crohn's disease. Specifically, Crohn's disease is chronic, meaning that it will last your entire life, and there has not been a cure found for it yet. Prognosis can vary from patient to patient depending on how severe the cases are. A patient may be able to go into full remission and have no issues in their day-to-day life, or they may be battling for a long time before they get to that part. It really does depend on the patient, how they're treating their body, if they're going through stressful situations, how they're really dealing with their diet. A lot of these factors come into play that you may not think, and that actually affects a patient a lot more than they think, actually. Maintaining a good diet can actually help with this and is able to have less flare-ups and less abdominal cramping throughout the patient's life, kind of like I mentioned right now. What is proved for certain people is a low fiber and a low processed food diet. So kind of sticking with a lot of whole foods, kind of sticking with low fiber, very rich in protein, kind of lean meats, chicken, fish, stuff like that is what we've seen in previous research and a low processed food diet, so basically not eating like unhealthy food, kind of simple stuff like that really goes far with people with Crohn's disease. Crohn's disease can affect anyone, but most cases are caught anywhere from the ages of 15 till people that are 35. For some reason we haven't found out, but it is actually more common in females. Smoking can play a major part in this, and is actually a more influential factor in Crohn's disease because the NOD2 obviously gene is getting mutated, and it leads to this disease genetic predisposition as well. The history of this disease. Before 1932, the condition was misdiagnosed or not recognized as a unique disease. Doctors noticed symptoms like abdominal pain, diarrhea, and weight loss, but they did not know the cause of them. That was until 1932, Dr. Crohn and his colleagues published a paper identifying a specific pattern of inflammation, mostly in the terminal ileum, the last part of the small intestine, like we mentioned before, which led to the naming of Crohn's disease, named after Dr. Brill. The most studied gene linked to the Crohn's disease is the NOD2 gene, which plays a role in the immune system's ability to detect and fight off harmful bacteria. Mutations in this gene increase the risk of developing the disease. And as you can see in the bottom right, this is Dr. Burhill Crohn. Some famous people with this condition that you actually might know from your day-to-day life is going to be we have Trevor Noah in the right corner. He's actually a famous author that wrote a couple of books. We have Pete Davidson, which is also another famous actor actually instead of an author. He's been I think he made a movie called Staten Island, I believe. I'm not sure. But I do know he's a famous actor. And we have Mr. Beast, or his real name being James Stephen Donaldson, popularly known as Mr. Beast. And all three of these people have been able to get into remission for their Crohn's disease, which just proves like people are actually able to like live a very well life. Besides having this terrible condition, people are actually able to thrive and be able to be good things later on in their future, even with such a terrible condition. And actually, if we're talking about famous people, I actually have Crohn's disease myself. If we go back a couple of slides, we're able to see this was actually my intestine. So I just thought I'd throw a picture on to show you guys an example of an in-person piece of intestine that got taken out of me actually. I actually had an anastomosis, so I had to get the bowel resection. So I was able to get part of my intestines taken out, or that part of my intestine specifically, the stricture part of my intestine taken out. So it was the bowel resection here, and from there I was able to make a full recovery, and I'm living a great life now, which I'm so thankful for every day. But yeah, that is my presentation done. I have a couple of my resources here, and yeah, thank you so much.